Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thank you all for your continued listening of Behind the Knife. While many long-term listeners of BTK have used our podcasts and resources while in medical school, we now provide resources tailored to medical student general surgery curriculum. Over the past 10 years of BTK and in our day jobs, we have dialed in the specifics of what medical students need to dominate their surgery rotation. It contains about everything you need to include review text, video, audio segments, pictures, reviewing over about 17 disciplines that you will encounter during your time of service. Enjoy the series and dominate the day.
Hello, everyone, and welcome back to our ASGBI series here at Behind the Knife. My name is Agnes Premkumar. I'm one of the Behind the Knife Education Fellows, and I'm a general surgery resident who will be representing the U.S. side for this discussion. And I'm joined here again by our UK-based co-hosts, Jared and Gita.
Hi, I'm Jared Wohlgemut, a surgical resident based in the UK, and the current president of the Moynihan Academy. We are the resident group of the Association of Surgeons of Great Britain and Ireland, or ASGBI.
Hi, I'm Gita Lingam. I'm a surgical resident in the UK, and I'm the vice president of the Moynihan Academy.
We're here to pick up where we left off last time regarding AI. We had a few more points to discuss. Namely, what's the role of AI in under-resourced settings? And what are some ethical dilemmas in AI? For example, are we all going to lose our jobs to the machines?
We hope not, Jared, but I'm sure it'll be an interesting discussion. So let's meet the team that's helping us explore this topic again. It's my pleasure to reintroduce Dr. Eric Nelson and Dr. Ellen Larson from the U.S. side. Dr. Nelson is a surgical oncologist working at the Brook Army Medical Center in San Antonio, and Dr. Larson is a general surgery resident at the Mayo Clinic, who's currently in her research time and finishing up her master's degree in AI and studying the role of machine learning within surgical practice.
I'm also honored to introduce Dr. Mukherjee, who's representing the UK side. He's an MRC and GSK surgeon scientist, alongside being an honorary consultant, general and major trauma surgeon in Liverpool. Okay, so in our discussion of AI thus far, both the US and the UK are both high-resource countries. But how do we see AI fitting into lower resource areas? Maybe Dr. Nelson, you can kick us off with a military perspective. Do we see this being used in battlefields?
So that question really addresses one of the original vision for surgical robotics was in battlefield trauma care and in rural surgical access. Reality has unfortunately proven much more complex than that well-meaning and inspiring vision. And I can address both contexts. Honestly, they deserve a couple of different interpretations. So as a military surgeon working in a military medical center, this carries personal weight to me. So the original DARPA version inspired trauma surgery on a wounded soldier performed remotely from safety, but battlefield realities of that vision unfortunately resulted in different and less ideal scenarios. So current military trauma emphasizes damage control. Okay, stop the bleeding, put your finger on the hole, control contamination, and evacuate to definitive care. These interventions really save lives. We're talking about early tourniquet application, hemorrhage control, airway management. These are relatively simple, but they demand rapid decision-making amid chaos and danger. AI and robotics don't really meaningfully address that core direct technical challenge. Now, that doesn't mean that they're worthless, though. Where AI could genuinely help is in predictive triage. So imagine wearable sensors on every soldier continuously streaming in physiologic data with AI algorithms determining early hemorrhagic shock before clinical signs manifest. That can trigger earlier evacuation, especially in the event that their casualty is now incapacitated and can't tighten their own tourniquet. AI-guided ultrasound can help a combat medic identify intra-abdominal hemorrhage without radiology training. These augmentation tools serve human judgment. They don't replace that human judgment, those set of human hands out there on the field.
I believe in part the robot was also envisioned to fit into these low-resource areas, such as military zones, rural areas, in order to help provide essential surgical and expert care. So with the integration of AI and robotics, I'm sure the reach could span even more.
That, unfortunately, faces unsurmountable physics. The surgeon versus the laws of physics, my money's on the laws of physics. Battlefields aren't known for reliable internet connectivity, although we're getting better at that. So autonomous robotics becomes the only option, and that returns us to technical limitations that we earlier discussed. And I must say candidly, we're not close to developing autonomous surgical robots in combat situations. The reliability requirements exceed our current capabilities by orders of magnitude. While operating, and we do this, I train for this, while operating in some makeshift OR, while somebody is ballistically trying to right-size my own existence, what I need is a better retractor, better lights, and a sucker that actually sucks. There's a different paradigm in rural access to surgery, and that presents more realistic challenges and opportunities. Now, the problem isn't emergent trauma, really. It's access to specialized expertise, right? A general surgeon in rural Montana might encounter a complex pancreatic mass maybe once every few years, and they're not going to go after that, really. But AI-powered decision support could show them similar cases or optimal approaches to perform a palliative operation, and can show them pitfall avoidance. Telementoring is another great tool. It already exists. An expert surgeon can remotely guide in and can take a local surgeon through a slightly more complex procedure. But there is an even more ambitious vision. This is semi-autonomous surgery for straightforward procedures, supervised remotely by a specialist. A rural hospital with a surgical robot performing routine hernia repair can be monitored by a real-time surgeon halfway across the country and who can intervene on an as-needed basis. There is no shortage of surgeons who would love to post up at home with their own personal Da Vinci console to help from afar. I think that'd be a great way to work. Nice thing to do in retirement. But here's the uncomfortable truth. What we're proposing is extremely expensive, technologically sophisticated. Rural hospitals right now, especially in America, are struggling to maintain even basic surgical capability. They're not going to be able to afford a $3 million robotic scalpel. They're not going to be able to support that AI infrastructure. While the military certainly could, that battlefield medicine requires rugged, simple, reliable technology, and that's basically the opposite of cutting-edge AI systems. So perhaps the question isn't, can we deploy AI in those settings? Which we probably could. But the real question is, should we? And in my opinion, probably not. AI can help, but it's not the solution to surgical access disparities. Those are fundamentally problems of healthcare infrastructure, workforce distribution, and resource allocation. Technology alone is not going to fix the systemic injustice.
To second Dr. Nelson, after that really eloquent description of the principles that we should really utilize for developing AI, I think that the key point is that technology that is looking for an indication is philosophically flawed when it comes to clinical development. I think it should be the other way around. Clinical science, our clinical practice has always been as physicians, surgeons, identifying indications and then utilizing the resources around us to actually benefit patients in a much better way. And so the whole principle of AI has to be considered within that context. Thinking that it's not about AI surgeons or automated surgery or AI bots or replacement of surgeons, but actually thinking about creating an augmented surgeon where we utilize AI to raise our situational awareness or increase our precision when it comes to operating. Those are the instances where I think clearly things are justified, and that's what I think we need to focus on.
Thank you both for that. I think that the framework to keep in mind about understanding where AI can be utilized in a justified manner in surgery is really an interesting topic. Just to pivot a little bit, I remember reading back in July that Johns Hopkins had actually trained a robot successfully to perform a cholecystectomy. The robot obviously took a longer time to complete the operation, but the results were pretty remarkable. What do you all make of this? Do you think our jobs as surgeons are endangered, that we should find another career to invest our time in?
Great question. Topical, and I love the story when it came out. In fact, the work behind this innovation is really great, and it captures both the promise of AI, but it also basically displays the hype around the technology itself. And to actually understand things properly, I think you need to understand that the common consensus is, amongst most experts, that robots will not be replacing us in any way or form as surgeons. And I'm sure that's a big relief to many who are starting their surgical careers. But what I think will happen is that the use of AI will basically redistribute and reform what we do as surgeons. So the surgeon of the future will be orchestrating robotics, imaging, data streams, and so on and so forth, rather than just simply operating manually. So a very different skill set that will become much more diverse. And the whole thing about cholecystectomy and having an automated robot, I think made me think and consider that the real question isn't actually, will AI replace us as surgeons? But actually more the point is, will surgeons who use AI replace those that don't? And I'm sure in the future, the answer to that question is going to be, if you don't know how to utilize the technology and apply it appropriately, you'll probably be replaced by someone who's better at it.
I'm going to challenge you on that one, just playing devil's advocate. I mean, many years ago, people said that nobody's going to want a personal computer in your home. That's ridiculous. And then people said, well, nobody's going to want a telephone on your pocket. Like, you've got one at your house for that. Why would you want that? So I think, and then there's famously people saying that a World Wide Web would not be of interest to anyone. And obviously, like 10, 20, 30 years down the line from each of these hilarious quotes, we can laugh at them. So for somebody today saying a robot will never do an operation, I don't know, maybe they will. How close are we? And maybe the question is, in how much time could a robot perform an independent basic operation?
So what's really important to consider is that the study published from Johns Hopkins was on ex vivo organ models, not a clinical real-time setting. And I think the capability is clearly there, and it requires development. It was great as a proof of principle or a proof of concept study, but you're right that in terms of scaling things up, there are going to be some inherent challenges. And I think that's predominantly going to be twofold. Firstly, dealing with patient variation, and then dealing with patient acceptability. So if we consider patient variation, the question remains, how is an AI robot going to adapt to anatomical variation or inflammation or fibrosis when operating that might be entirely unique or different according to the patient in front of them, and something that they've never encountered before on the basis of the data set that they've been trained on? Secondly, would patients accept a robot operating on them? And that's one of the issues that the automotive industry is tackling with Tesla's automated cars. As a person trusting an automated robot to perform a function that carries a significant risk at this moment in time, I don't think the patient acceptability is simply there. Clearly, we do require certain safety standards and regulations that can prove that these technologies can be safely implemented, validated, and then scaled up. But with technologies, innovations, you're quite right to point out, Jared, that at the initial stages, there is always an at-risk group that takes the leap. So, for instance, in my own field, considering drug discovery, we have first-in-human trials on healthy volunteers that have never experienced the drug before, and it's simply there to establish lack of toxicity or a good side effect profile. So I think it's inevitable that we will have to develop such studies to really scale up the approaches that you're proposing and Johns Hopkins have proposed in terms of new innovation. It's very difficult to put a number on it in terms of timescale, because at this moment in time, certainly within the UK and Europe, the general surveys suggest that the public remains skeptical. and untrusting of such technology to perform such surgery. So I don't know if our American colleagues would like to elaborate on this further, but I'll hand over to them.
I love what Dr. Mukherjee said, because I think he's sort of honing in on what in AI ethics we call the accountability paradox, which is that when we have AI systems that make decisions and make choices and do actions without input that is directly understandable to us, we have this problem where who is held accountable for what the AI has done? And from a moral perspective as physicians, from an ethical perspective, as well as from a legal perspective, having a robot perform actions on a patient independent of a human operator, there's no ethical solution and there's no ethical way to reconcile that at this time, because if the robot makes a mistake and harms a patient, it's difficult to assign accountability for that. And as we all know, even the most routine operation, cholecystectomy, appendectomy, central line placement, these can all go catastrophically wrong within moments. And I know from my own personal experience, and I'm sure the experience of everyone here, is that when that does happen, the best possible outcome for the patient is to sit down with the patient and their family or their loved ones and explain to them what happened and take accountability for that. In the case where we have AI performing surgical operations on a patient, accountability is not there. And there's been a lot of ethical debate about this. And I do not see, at this point, I do not see any progression in the ethical literature toward a solution that allows us to do things like this in an ethical manner. So I think that's going to be a huge hang up for developing any type of autonomous decision making in the actual operating room that is done by an AI. Now, that being said, I agree also with the idea that we're all going to be seeing AI in our surgical practice, whether or not we like it. But I think it's going to creep in ways that are a little bit more subtle. I think we're going to start seeing things like structure identification popping up on our robot screens. I think we're going to get intraoperative decision aids. I think all of those things are going to be widely used within the next few years, and definitely within our lifetimes. But I really struggle to envision from an ethical standpoint any future where the surgeon's hands are not on the console at all times and on the patient at all times. I think that's really hard to see in the future.
Yeah, Dr. Larson really hit the nail on the head there. As primarily a robotic surgeon, I recognize that even right now, there are times where the robot does assist in a way that my hands are only indirectly connected. So for instance, if I am suturing something extremely fine, I can change the sensitivity of the movements of my own hands on the robot. And even though it is still my motion, the computer is calculating exactly how much my hand moves on the inside compared to how much it moves with me at the console. Now, that is a computer that's in the way between me and the patient in the same way that the scalpel is. And so the way that AI comes into our practice is going to be very gradual with those little steps that people get used to all at once. When I first started off on the robot, the patients would ask me, what, you're not going to be like scrubbed in next to me? And I'm like, no, I'm not. I'm going to be sitting right over there. My assistant's going to be scrubbed in with you. And it took a while for them to come to realize that, but now it's so common that people don't mind it at all. And it's those little tiny increments that are going to get us through this. Now, that does not address Dr. Larson's very astute ethical conundrum as to, okay, who's actually responsible? And the answer is the surgeon's responsible, and anybody who disagrees can hang up their white coat right now. In philosophy, in mathematical philosophy, if there is no answer to that, then it becomes an axiom. It is something that must be true even though we cannot prove it. And in the age of technology-assisted surgery, the axiom must be that the surgeon is responsible. Now, going back to the autonomous cholecystectomy, that was very fun. I liked the paper. It was a great achievement. And they used another program called the Smart Tissue Autonomous Robot that operated on top of the Da Vinci. And it demonstrated, certain tools that are going to be able to assist us in the next generation of robotic surgery. But like say, even in the Da Vinci 5, that haptic feedback solution is a way for the computer, the intelligence that computer has, is to interfere with the surgeon. It will push back on you if you're putting too much tension on the tissue. And that's a good thing, but it is ultimately the robot standing in the way of the surgeon because the robot thinks or has been programmed to say, hey, no, you can't actually pull that hard. And ultimately, the surgeon is still in control of that. And that is the first step in the long pathway towards a truly surgeon robot AI collaboration. And it represents a remarkable engineering achievement. These researchers overcame these technical challenges around a real world tissue characterization, dynamic mapping, and they were able to use the device relatively safely. It demonstrates that AI can do way more things than we think it can right now. Again, I think that a lot of this is going to be much akin to, the paradigm of nuclear fusion. It's always 10 years down the road. That autonomous surgical robot for many decades is just going to be 10 years down the road. And so that's why, because of those caveats, I'm not concerned about losing my job, and I don't think you really should be either. And one of those is the real reason why I think is philosophical. Surgery is not a single procedure on one organ in a healthy pig under controlled laboratory conditions. That this is an art based on infinite anatomical variations across multiple pathologies, infinite patient factors, and unfortunately unexpected findings. It's the complications that demand surgical judgment. And what happens when that autonomous robot encounters inflammation, aberrant arterial anatomy, suspected malignancy, unexpected bleeding? AI excels at pattern recognition, but struggles with genuine novelty. And that's why I love surgery, especially surgical oncology. That's why everyone who's listening to this podcast loves surgery, because even the most routine operation is novel. And I envision AI as a surgical co-pilot rather than an autopilot. So as far as my prediction, AI will transform how we operate, but surgeons will not be obsolete any more than pilots became obsolete when the autopilot was invented. The aviation analogy here is a pretty good one. AI can handle the routine task, which frees me as the surgeon for high-level judgment and high-level interventions when the real systems fail. In aviation, that's called threat and error management. In surgery, it's just surgical judgment.
Thank you, everyone. That was an amazing, amazing discussion. So we've learned a lot on this podcast already, but just quick fire, one point that you think the listeners should take home from this podcast. Dr. Mukherjee, if we start with you.
Thank you. I think that basically our responsibility as practicing surgeons, and for all trainees and residents, and for any other surgical colleagues listening to this, is to shape the future of our practice with AI, putting what I term the 3 E's at the forefront. That's evidence, ethics, and equity. We need to all learn this new way of doing things and partner with data scientists to ensure that AI is deployed within the settings of the patients we treat truly for their benefit and not for profit margins. As clinicians, I think that has to be our imperative.
Yeah, amazing. Thank you. Dr. Larson, one point take home for the listeners.
I think AI is a great opportunity for us to have a new era of creativity in surgery, for us all to think about how enhanced decision-making and information processing can be incorporated into clinical practice. And if no solution exists, go out and find people to help you create it. Don't be afraid to approach your partners in computer science and mathematics. These people are looking for ways to apply their knowledge in high-impact clinical ways. So we are really the driving impetus behind our own AI future as surgeons.
Go on, Dr. Nelson.
I'd like to kowtow on what Dr. Larson said, and that really this is a unique moment in surgical history. And the next decade will see AI integration to nearly every aspect of our practice. And if we do this thoughtfully, it'll make surgery safer, make it more precise, more accessible. But if we do it carelessly, it will introduce new errors. It will exacerbate inequalities, and it will damage that sacred patient-surgeon relationship. All right. The difference between those two futures isn't primarily technical, but it's human. It depends on whether we, as a surgical profession, through the guide of AI's development and deployment, insist that it serves our patients rather than merely serving institutional efficiency or commercial profit. So I challenge every surgeon and especially every trainee listening, don't be a passive recipient of AI technology. To be active, be especially critical and engaged in your participation in creating the future of surgery. I want you to demand transparency, insist on validation, maintain your healthy skepticism, and most of all, preserve your humanity. Your patients deserve nothing less. Our profession demands nothing less. You too deserve to benefit from this extraordinary new technology. Advocate for yourselves. To our residents, you must be so loud that when the widespread AI adoption comes for academic medicine, make sure that saving your time with a bit of AI investment will be seen as a worthwhile endeavor. So remember, the needs of the patient come first. But, when you're a trainee, your needs can sometimes come first too. So thanks for your attention, and dedicate your heart to the healing with all that we serve, and the future's yours now.
Wow, those are just some great tips and takeaway points for us to all mull over. Once again, thank you, Dr. Mukherjee, Dr. Nelson, and Dr. Larson, for your time and for your wisdom. And thank you all for that super interesting discussion. I'm sure we'll be thinking about all the points that were raised moving forward as well. We truly appreciate it.
Yeah, and thank you to the listeners for tuning in. I know in this episode, there were a lot of similarities and agreement between the approaches to AI, both clinically and academically, between the US and the UK. But be on the lookout for more of our episodes in the future, where you can judge as the listener who does it better, the UK or the US. And remember to
dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.